quickly. But hey, we are here. And once again, we've got an excellent guest, and I'll introduce him in a moment. But before we do so, I just want to remind our lovely listeners out there that, come in and join us and be part of this discussion, part of the conversation, ask questions, put comments. Now, there's various ways you can do that. You can obviously go online and go onto ramadan.fm 87.7, or give us a call on 0116 484 2086. Send a text message to 077 48 855 055. We are also live streaming on Facebook and YouTube as well. So come on, listen to us live, put the comments in, or we will have, because it's recorded on, and we'll have a YouTube running afterwards. So you're more than welcome to join in then. Even put in questions then as well, and we'll try to get back to you. But hey, I don't want to waste any time because we've got an excellent guest today, and he's an internationally renowned professor. I've known him for a few years, and it's an absolutely pleasure. We've got none other than Professor Dinesh Bhugra with us today. Now, Dinesh, I asked him to please send me your bio, and he was extremely modest and sent me a couple of lines, but I would be doing disjustice, if that's all, not justice, if I didn't add a few more onto there. Now, what he sent me, which he's the Professor Emeritus Mental Health and Cultural Diversity of King's College London. And I can tell you for a fact, Google his name and you'll see the amount of work that he's not just done in the UK but internationally. He's also the first non-white president of a Royal College, specifically the Royal College of Psychiatrists. So basically, if you want anyone's example as to who broke that glass ceiling, Dinesh is your man. He's not only just done it in that area, he's done in so many other areas. And the good thing is, Dinesh is such a humble and a modest man, and he's always out there to help. I had the opportunity to meet him recently in Pakistan at a conference, and people absolutely loved him because he's a very personality of such an easygoing individual. He's also the previous chair of the Royal College of Psychiatrists Transcultural Special Interest Group, which he almost single-handedly set up and set off as well. And he's written a number of books on culture and mental health. For me, if you ask me who is the guru of culture and mental health, which is very much near to my heart, it will be Dinesh. If I go to anyone to understand it, it is Dinesh. And Dinesh, on that note, I want to welcome you to the show today.
Assalamu alaikum and Ramadan Mubarak.
Thank you very much, Dinesh,
for inviting me.
The pleasure is all ours, Dinesh. It is definitely ours. And it's wonderful. Thank you for taking out time from your busy schedule on a Easter Sunday and being with us. And I've said enough, and I'm sure, Dinesh, we want to hear from you. Now, the topic of today, we're talking about the NHS, the advent of the NHS, the history of the NHS, and we're going to follow this up by talking about the contribution of South Asian healthcare professionals. I'm saying healthcare professionals on purpose and not doctors, because it's been that way. So, Dinesh, I'm going to open up an open question. So over to you, Dinesh. Tell us a little bit, give us a bit of a taste, and then we'll come over to your experience when you came to the UK of the NHS.
As we all know, National Health Service was established in 1948, 4th of July, and it'll be 75 years next year. And it emerged from the shadows of Second World War, which is quite important because I want to come back to that. Because in 1944-45, Sir William Beveridge, who was eventually ennobled and became Lord Beveridge, did a wonderful report. And he talked about 5 giants which need to be slain. And these giants were want, squalor, disease, ignorance, and idleness. And as a result of that, when Labour came into power immediately after the Second World War, various programs were set in place, from social security to healthcare, and National Health Service remains the prime example of getting access to healthcare irrespective of your ability to pay. And what it has done over its 75 years, I mean, again, one of the big questions really is that, we still have disease, we still have squalor, we still have ignorance, and to a degree want, but um, idleness to some degree has changed. And what that has done is, and when you ask people, I mean, most individuals, when we are ill, we can live with our symptoms as long as we have a job, we have a house, we have friends, we have relationships. And one of the big tensions in the NHS is that it has been a victim of its own success in the 75 years. And, society is not as it was in 1948. People are living longer, and certainly until recently, longevity was continuing to increase. But over the last 10 years or so, it has reached a standstill, if not fallen back. But what that has meant is that as people are living longer, you're getting more and more complex comorbidities, both physical and mental. And what that does is puts additional pressure on the NHS. And one of the big tensions has been, how do we keep funding the NHS to make sure that people who need it most get it without any um, problems? And having seen different healthcare systems around the world, um, you know, UK still does not spend as much on healthcare as do other high income countries like France and Germany, and USA is completely out on a limb because it spends a huge proportion of its gross domestic product on healthcare, and yet it's not universal. And perhaps we can have a discussion about that in our chat. But one of the big challenges really is that if we were setting up the National Health Service today, would we set it up in the same way that we did in 1948? And if not, what are the lessons? What do we need to change? And there are quite a lot of things we could do differently. We could integrate primary care and secondary care. We could integrate social care and health care. We can integrate public health and healthcare. And we also need to look at, and I'm not advocating that we do that, but we need to look at integration of physical and mental health care. Because for our communities in particular, quite often we present with, particularly if you're stressed or distressed or anxious or depressed, you present with physical symptoms. And what then happens is that we get endless investigations, which all come negatives. The doctors feel disheartened, patients feel disheartened. Whereas the truth is that we have a different way of expressing what we are feeling, and that gets forgotten in any kind of healthcare system. So I think there are challenges, and one of the discussions that I've had with various politicians over the years is that if we were setting it up, would we set it up in the same way? And the answer is no. And if we look at as we are coming out of pandemic, and it's by no means over, this is the right opportunity to look at the strengths and weaknesses of the National Health Service, and how do we as citizens um, respond to the needs of the National Health Service, and how do we look after our own physical health, mental health, and well-being. And I think what it what it raises is the notion of social justice, which is quite dear to my heart, which is about capability to be healthy. How do we make sure? And I always use the example of capability to be healthy as a kind of pyramid, that the base of the pyramid is the government, which funds healthcare, but it also educates, and it is about giving the right information. And NICE guidelines are a great example. To how do we educate people into looking after their own health? And between the government and the individual is the community, and that's where teachers and religious leaders and community leaders come into play, because they can work with the community to try and educate and say, well, okay, you need to do A, B, and C. And then obviously, as the next step is the family. And as family members. It's upon all of us to look after family members when they're not eating right, or whether they're not doing exercise, whether they're feeling anxious or stressed, and how do we deal with that? And then on top of the pyramid is what an individual does, and that capability to be healthy. So I think we need to support the NHS. Not, you know, um, I'm not saying that it is a kind of blind um, following, but it is a responsibility for all of us to support the NHS and to make sure that we and those we love stay healthy, and we can look after it, our physical and mental health.
That's so beautifully put, Dinesh, and I couldn't agree with you more. And then the few things that you just touched on is, the whole concept of health itself. I mean, Britain is a multi-ethnic country, and you've touched on various forms of presentations, and especially in not just in mental health, I suppose in other healthcare specialities as well, where it's so important for specialists, not just doctors, but all healthcare professionals to understand the message that people give out there, and I think that's really important. The other thing that what I think which obviously triggers something in my mind, is the whole concept. I know you're absolutely right that COVID hasn't gone away; we're still living with COVID, but the whole concept of what happened during COVID and how we were able to flex ourselves to adjust and readjust so that we can respond to the whole COVID. So if we can do it during an adverse episode, why can't we take that as an example and say, look, is the NHS really working? I mean, it's wonderful, it's brilliant, but there are edges, or more than edges, to be shaved off, tightened, pointed out, etc. And if we can do it during COVID, why can't we do it otherwise? I suppose there needs to be an urge, Dinesh. Where would that urge come from?
I think the urge is already there. I mean, if you remember when we went into the first lockdown, and the Prime Minister, in one of his Downing Street press conferences, asked for people to volunteer to look after, those who were vulnerable, and he wanted 250,000 volunteers. And as soon as the registration opened, the 750,000 people had signed up. So to me, that indicates a sense of purpose, a sense of altruism, and a commitment that people have. And as a result, in the COVID, I mean, um, our street and various other places, I know people set up WhatsApp groups to making sure that elderly were being looked after, and they had access to food when they needed it, etc. So it can be done. I mean, there is plenty of goodwill in the community, and particularly South Asian communities are much better at um looking after the elderly, looking after the vulnerable, whether it is through religious activities or teaching or community activities, and the sense of belonging as a very much collectivist culture is much stronger. And COVID has illustrated that it's not missing in the larger population either. So it's how do we tap that? How do we make sure that people are able to use that? And I always maintain that more and more people are retiring, and there's partly because of the success of the NHS, as I said earlier, there's longevity. So people are looking for things to do. So why can we not use volunteers? You use people who will reach out and look after those with chronic physical illnesses, chronic mental illnesses, those who are vulnerable, who may be lonely, who may be isolated, who may feel alienated, to try and provide them with emotional support. So one of the big challenges really is, what do we learn from other parts of the world? And there are wonderful examples from around the world where resources are not as rich as we have them, but people can, uh, through volunteering, through community activities support each other. And, if we have time, then I can illustrate that with those examples.
Sure. No, no, thank you. Thank you for that. That's really important points. And I will be coming back to some of the challenges and the milestones and the successes of the NHS, some of which you've already touched on, but I will be coming back to those. But before we do that, I just want to remind our listeners that you are listening to Ramadan Radio 87.7 FM. So call in on 0116 482 2086 or text us or WhatsApp us on 077 55055. You can listen to us now or post radio show as we are live streaming on Facebook and on YouTube as well. Dinesh, I'm really interested. I'm sure the listeners would be really interested to learn a little bit about your journey, because fast forward maybe 30, 40 years into the advent of the NHS, we started to get an influx of doctors from, or correct me if I'm wrong, it might have been earlier than that. I'm a little bit interested on the advent, but also your experience when you came into the NHS. Dinesh, is it okay if we can spend a little time just talking about that?
Yeah, sure. I mean, the part of the story, uh, I'll come to my personal story in a minute, but the story with South Asian healthcare staff moving to the UK was immediately again after the Second World War, as people were invited to come in and build a pretty shattered economy and that's why you have lots of people from the Caribbean and from South Asia coming over, and partly because historically the connections had been fairly close. So lots of doctors and nurses and pharmacists and other healthcare professionals took the opportunity to come over. And there has always been, I mean, it's not an exaggeration that NHS has been supported very heavily by South Asian health professionals. And that has meant that quite often people coming over have ended up in unpopular specialities and unpopular locations. Um, and they've done their best. And partly it is also to do with the sense of altruism. Unlike a very kind of money-based, insurance-based healthcare system, lots of people like me preferred the UK system because it is um, much more equitable. And one of the tragedies I think it's probably a global issue, but even you know, in the UK, but also in South Asia, is about workforce planning. Now, um, India, for example, produces something like 88,000 doctors a year from various government and private medical colleges. And yet, uh, to the best of my knowledge, the number of training posts in psychiatry, for example, are less than 1%, whereas we need 10% of doctors to go into psychiatry to make sure that people's mental health needs are looked after. And what that indicates to me is uh, you know, I did my medical school from Armed Forces Medical College in Pune, and I belonged to that half of the intake who chose not to go into armed forces, which meant that when we finished training, we had to, find our own way. And right from the second year of medical school, I discovered that I wanted to do psychiatry, and it was quite a sudden movement in my mind. In that, I remember very clearly, one day I was cycling back from, those were the days when everybody had a bicycle, and bicycle was seen as the best mode of transport. Um, from the dissection hall to the hostel. And what struck me was that, we all have similar anatomies and we all have similar physiology. So what makes us all so different? And that got me thinking and got me reading, and kind of came across Freud, came across history of uh, psychiatry, both in the Middle East and in India. And particularly, I was quite interested in. I remember reading a book about mental illness in Egypt in ancient times, and that sort of struck a chord with me. And partly because there were very few training posts in psychiatry, and I could not. I mean, I applied to half a dozen places, had one interview, did not get the job. And so I came over basically to do the training. And, I spent 5 years in Leicester before moving down to London. And once you spend some time in one healthcare system, quite often it is very difficult to go back, because healthcare systems are very different, support systems are very different. You do not have access to same level of multidisciplinary teams and so on and so forth. So I kind of stayed on. And that, uh, in short, is um, my story.
Wonderful, wonderful. And it's great to hear, because these are, for our listeners to know, these are the very early, what Professor Dinesh Bhugra is referring to, are the very, very early days of when South Asian doctors started to come to the UK to offer their services to healthcare, NHS in particular. And what a time that would have been. Dinesh, I know you've touched on some. What are some of the challenges that you faced?
There are, I mean, a lot of challenges. I mean, firstly, even though we were taught in English, we studied British textbooks, and certainly in my era, we still read, various textbooks which were written by British authors. Um, Language still matters. So when you come over, the simple terms, dialect, accent make a lot of difference, and that plus the simple things like the idea. I mean, again, I sort of subsequently um, did masters in sociology and another masters in social anthropology, but you kind of learn about cultures. And South Asian cultures are multi-active cultures, as you know, that we do multitasking at any given time. Time is kind of relatively loose concept, and we just try and we'll be on the phone while we'll be doing something else, and somebody else is talking to us in the office, so you're doing 3 4 things at the same time. And you realize that you know there is something called linear active cultures, which means everything has to be done just so, in a sequence, um, in a kind of controlled way. And it was quite a shock, because I remember you know checking with a colleague, and, oh, shall we meet for dinner? And the individual took out the diary and said, oh yeah, how does the November the 14th sound? And we were in May. And this was a complete shock to me, because in India, as in Pakistan and elsewhere, I mean, if you want to go, you go to somebody's house. If they're there, you meet with them, have a cup of tea, have dinner. If they're not there, then you just go and do something else. So it's kind of, that was a big shock. And I remember inviting some colleagues for dinner, and 8 o'clock, would that be okay? Yeah, fine. And at 7:59, I see one individual kind of walking past the house. What's wrong? Did I not give the right address? And at 8 o'clock, the doorbell goes. The person comes in, and I said, "Well, why did you go?" Um, and his explanation was, "I was a minute early." So those kind of things, you really had to adjust to, because it's a very different way of thinking, very different way of working, different way of responding. And in addition, I mean, I think certainly, I mean, Leicester perhaps less. than any other, but there were sort of, those kind of racial overtones and tensions, sometimes from patients, sometimes from colleagues, sometimes from, people you didn't know. And that made life difficult at times because you felt, you know, here I am. And, even in um, the Royal College of Psychiatrists, I mean, those were the early days, as you said, and somebody in the college council said something like, we paid for you to be trained. And I looked back and said, but I'm working here, so I'm kind of paying back. And, things like that. And then, somebody kind of turned around and said to my face, basically, what do we have to do to get you to speak proper English?
Oh, goodness.
And you think, okay, there's some truth in that. English is my third language after Punjabi and Hindi and dabbing of Urdu. But it, and I know that, in our language, quite often there's no concept of definite and indefinite articles, and occasionally I miss them, and occasionally I put them in the wrong place. I understand that. But what was kind of hurtful was not that they said it to my face. They then went to the head of the department in the college and said, what do we have to do to get the dean to speak proper English? And those kind of things you remember. Hurtful, yes, but you also have to take it in um, your stride, because otherwise you'll forever be worrying about them. So it's been, I mean, I've been incredibly fortunate, and in lots of ways, people have been very kind, very generous, very supportive, um, and hopefully it has, illustrated to others that it can be done. I mean, one thing is that, you have to work twice as hard as some other folk.
Yeah, absolutely, Dinesh. And, it's, I'm glad at the end you have highlighted the positives, of people being very supportive out there. I mean, I've seen a lot of people, in professionals in my career of being helpful, but, we've also experienced the other end of it, like you've highlighted. And I'm sure most of our listeners from South Asian or non-white backgrounds, in some shape or form, may have experience some form of blatant or sort of very subtle kind of discrimination and racist comments, which are now topics of discussion. And I'm aware, Dinesh, and you've been very much at the forefront, along with other colleagues, in trying to challenge these very discriminations, and a lot of work has gone into it. Do you want to sort of just briefly touch on that? Because it's then going to take me on to the next question, I suppose, is what you would say to other non-white doctors who are very, very ambitious, very enthusiastic, and genuinely want to do well for the NHS and for their careers and for organizations. But just if you can just slightly just touch on what work has already been done and what you think needs to be done.
I think that there are sort of quite a lot of things. I mean, certainly things have changed in the last 40 years. People are much more aware of, things which were completely unacceptable 40 years ago, which were completely acceptable 40 years ago, are completely unacceptable now. So things have changed. People have moved on. And the fact that 60% of the medical student intake in many medical schools is South Asian origin and women indicates that the cultures will change further. So there has to be, uh, a big shift. And Royal College of Psychiatrists did a series of reports in the 1980s on the impact of racism and discrimination on both the staff and the patients. And just to put one correction, I was never chair of the Special Interest Group on Transcultural Psychiatry. It was established when John Cox was president and Dr. Parimala Moodley was the first chair, and she was appointed associate dean, and she changed the curriculum, rewrote the curriculum, taking cultural issues into account, and also uh, emphasized both the needs of minority psychiatrists, trainees in particular, and of the patients. And in those days, we used to have the college used to run regular induction days for trainees, 2 days twice a year for all international medical graduates to come to London and learn about the NHS, learn about the pressures, learn about the whole processes of registration and functioning and training, etc. So it's um, and then I think it must have been in the 90s. The college then invited Kamlesh Patel, who was um, in the Mental Health Review Tribunal and is now a member of the House of Lords, to come and look at the college policies on race. And he went through policies with a fine tooth comb. And then, there was a big shift towards um, cultural competence training for trainees and for doctors and other health professionals. And in sort of when Cornelius Katona was the dean, and that came about. So there's been a gradual shift. I mean, again, just to kind of illustrate you with an example, that for a very long time it was assumed that only Black and minority groups had cultures, whites did not. Um, and that notion has gone completely, that everybody has cultures at different aspects. And, even, to assume that, and I always joke that, we assume that London has one culture, it doesn't. You know, culture in Hampstead is very different from culture in Brixton. So, what we need to be aware of is the shift, and it is truly multicultural, but there are still issues to do with racism. There's still issues to do with discrimination. There are issues to do with bullying and harassment in the NHS structures and institutions, which reflect some of that institutional racism. That there's a perception of, um, you know, either that it's to do with creation of the other, so which validates my identity. So I have to create the others to make sure that my identity is valid, whether it is to do with gender or to do with profession or it's to do with speciality or sexual orientation or religion or whatever. And what, in a way, the college and the society at large are beginning to address some of those issues.
Thank you, Dinesh. No, it's a very nicely put. And I think it just takes us nicely on to the next question with all the challenges and all the difficulties. And it's really good to see that despite all of that, we've got household names like yourself who've been success stories, and we've got many, many successes to share. Briefly, Dinesh, can we touch on what the contribution, and I'm specifically because it's Ramadan.fm and because we are, mostly our listeners out there are from South Asian background. But you can spread it further onto other multi-ethnic backgrounds as well. But if you can just briefly touch on your experience having been here for so long and gone through your travel, your journey, as you've explained through the NHS, what do you think have been the contribution of South Asian healthcare professionals, or let's call it non-Indigenous healthcare professionals in the NHS?
I think there's been quite a lot. As I said earlier, that quite often medics from South Asian backgrounds as well as other health professionals have gone into specialities which were unpopular with local graduates, and they've gone into places which were unpopular and have not only made a life, delivered services, and improved services. And I think that goes without saying that without the contribution of the South Asian health professionals, NHS might not have been in the state it has. And the reflection in the first wave of COVID, the number of deaths in people from South Asian communities indicated quite clearly people who were in the front line of providing services, who were exposed to the deadly virus, caught it, and regrettably, unfortunately, died. So the contributions have been really both at a sort of micro community level, but also at higher policy levels, because with their interpretation of what's going on, and there have been lots of general practitioners who have provided superb, excellent services to very deprived, vulnerable communities, and as a result, have then had the ear of respective governments to bring about sustained changes. And just to sort of remind your listeners, the Professor Reena Arya, who is a professor of culture and arts in University of Huddersfield, she's just finished interviewing, I think something like 26 South Asian doctors about their experiences in the NHS, and I'm helping with some of that writing and analysis, and hopefully the book should be out later this year. And
Fantastic.
what is really fascinating being that there have been several interviews where it's been um, father and son who both gone into the same specialty or other relatives, indicating that there is the commitment on behalf of the community to the National Health Service is superb. It's par excellence.
Mm. Excellent. And just following on from that, Dinesh, what do you feel in relation to earlier on when we were talking about the whole concept of treatment and management and the presentation of individuals? It'd be really interesting to get your thoughts on the biopsychosocial model, this concept, which is obviously very, very helpful, but in a lot of ways, which can be a very Western model. Are we missing anything, or is there anything that we need to add to that in order to make it, considering the fact that Great Britain is a very multi-ethnic country, and a lot of the understanding is, and you're absolutely right, it's not just our South Asians, it's not just Arabs, it's not just Africans, it's not just from Latin America, it's also Eastern Europe, and like you've said, understanding of cultures from somewhere like Brixton to Hampstead, etc. It's totally different. Is there anything that we can add to this biopsychosocial model to make it even more international? I just want to add, Dinesh, when the ICD, I think it was the 9 or the 10 when it was coming out, or maybe the 10, what we use at the moment, when it was formulated on the panel of experts, there was only one person from a non-white background, which says a lot about the Western model of something that we use globally around the world.
That's a very good point, because for a number of reasons. I mean, I think for South Asian communities in particular, um, we see illness uh, in a very different way. Not, I'm not sort of saying in any sort of derogatory way, but we see it's, for example, I mean, it's a kind of issue of the concept of why body. Some foods cause why and others cause body, and some, um, and the interaction between mind and body. That Cartesian mind-body dualism does not exist in our cultures. Mind affects body, affects mind. Hence, we get lots of people presenting with somatic symptoms or um, physical symptoms, even when they may be distressed. And equally, people who have diabetes or hypertension or osteoarthritis, which is very common in our communities, they're much more likely to be depressed, but they may not see it as depression as the Western models would see it. So, and equally importantly, there is this whole impact that people see environment having, whether it's the weather, whether it is uh, something else, and a diet. So that's one bit of the model. The other thing that we never talk about in this country, um, particularly, is that if you prescribe a medication, 9 times out of 10, when I'm sitting in a clinic in India with friends, 9 times out of 10, the patient would say, how do I take it? Do I take it with hot water, cold water, with lassi or chai or whatever? And we know, and the next question would be, uh, kya mana kiya hai? How should I, what should I avoid? What should I not take? And we never discuss that with, South Asian community patients in this country. Um, and we know from, some of the work that we did, putting various informations together in different communities. Um, some communities prefer capsules, others like injections, others prefer syrup. Some like big tablets because they feel that bigger the tablet, more compound it has, and it'll be easier to, it'll have bigger impact. Other communities like very small tablets because they feel that this would have very concentrated effect. And therefore, they prefer that. Some communities like red pills, others like blue pills, others like green pills. And we know that people stop taking their medication either when they're getting better or they feel it's not doing any effect because we have not entertained the model that people are using. What do they see medication for? What do they see it's going to do? What are the do's and don'ts with the medication?
Mm.
And I think that is something that we need to change in making sure that people understand that this medication is and I always use the example of an orthopedic friend of mine who's got a wonderful um, series of information that if you are on this medication for this arthritis, um, you know माँ की दाल नहीं खाओ या मूंग की दाल नहीं खाओ या काले चना नहीं खाओ. So it kind of makes the patient aware that you are taking their concerns seriously, that you're on the same wavelength rather than, I mean, at one level, we talk about, um, giving patient the power and having some kind of equality. At another, we still kind of treat patients in a way that, you will do what I tell you to rather than, okay, what's your model? What do you think is wrong with you? What do you think is going on? And how do we work together to shift that?
Absolutely brilliant. Dinesh, I could go on and on listening to you and talking all day. Such a wealth of experience and pearls of wisdom. We've come to the end. Unfortunately, then time flies when you're having fun and when you're listening to yourself. And this is something that we experienced not long ago when heard some of your lectures and some of your comments in Pakistan. We've only got about 40 seconds left. In one or couple of sentences, any take-home message? Because obviously we are coming to an end. So a very quick message from yourself, Dinesh.
I think it is very important for everyone to look after their own health and look after the health of people around them. Um, Learn from the information that is given to you, interpret it correctly, and then use it to the best ability. And I would also,
We're just coming to the end now, Dinesh. It's been wonderful having you, Dinesh, and it's been a real pleasure. And thank you very much for sparing the time. We've been listening to